Next we have the nitrofurantoin. It is a primary bacteriostatic in nature, sterile at high concentration and in acidic urine. Gram-negative bacteria are mainly affected with nitrofurantoin. But however, due to resistance, it is currently now active towards only Escherichia coli, what we call E. coli. It is given for a urinary tract infection at a dose of 50 to 100 mg TID for 5 to 10 days. It is not recommended more than 2 weeks. Metronidazole is an antiprotozoal agent which is having broad spectrum coverage towards protozoa, and it produces a sterile action. That's the reason why FDA has approved this drug for protozoal infection. It is also having action towards bacteria. Bactericidal action towards anaerobic gram-positive as well as gram-negative species. When considering gram-negative species, they are having action towards bacteroids, Furobacterium species. It is having action towards anaerobic cocci such as Peptostreptococcus, and when considering gram-positive anaerobic bacilli, they are having action towards Clostridium species. Coming to the pharmacokinetics, it is having high concentration in the blood and is having high tissue penetration. The bioavailability is 100%. The dose given is 500 mg BD as orally or can be given as 750 mg BD or TID. In our country, metronidazole oral tablets are available as 400 mg dose and 500 mg metronidazole infusion bottles are available. The mechanism of action is it inhibits the nucleic acid synthesis by disrupting the DNA of microbial cells. Now let's have a discussion about tetracycline and chloramphenicol. Tetracycline is a broad spectrum bacteriostatic agent. Similarly, chloramphenicol is also a bacteriostatic and broad spectrum agent. The tetracycline usually consists of doxycycline, minocycline and tetracycline. The spectrum of activity of all these drugs are almost same. Minocycline is having higher lipophilicity than doxycycline. However, doxycycline is most efficacious than minocycline and tetracycline. It is available as oral dosage forms and injectable formulations. It is said that tetracyclines cannot be administered or should not be administered as these drugs can bind to the bone and the teeth of the child and cause permanent damage. However, the only tetracycline that can be administered to a child less than 8 years old if he or she is having severe life-threatening condition. Usually it can be preferred for children greater than 8 years of old. The usual dose is 100 mg to 200 mg OD or BD orally. 100 mg BD is given as intravenous administration. When coming to minocycline, the dose given as intravenous is 200 mg for first dose, then 100 mg PD. Maximum dose is 400 mg. In case of oral route of administration, the first dose is 200 mg followed by 100 mg BD or 50 mg 4 times. The mechanism of action of tetracycline and chloramphenicol is it inhibits the protein synthesis. Both are having bacteriostatic agent, which I have mentioned earlier. Chloramphenicol at high concentration is bactericidal towards Haemophilus influenza. The dose given is 200 to 500 mg 6 hourly, maximum dose 28 gram per day. Sulfonamides are the structural analog of para-aminobenzoic acid. As a result of being a structural analog of PABA, it inhibits the folic acid synthesis. The sulfonamides are classified into three: short-acting, intermediate-acting and long-acting. Short-acting consists of sulfadiazine, which is having an action of 4 to 8 hours. Sulfamethoxazole is an intermediate-acting agent which is having an action of 8 to 12 hours. Sulfadoxine and sulfamethopyrazine is having longer action, that is approximately 7 days. Other special preparations of sulfonamides are available. Those are silver sulfadiazine and sulfasalazine. They are bacteriostatic in nature but bactericidal in urine. If we are discussing about sulfonamides, we should discuss about cotrimoxazole. It consists of sulfamethoxazole and trimethoprim in a ratio of 20:1. Both are having 10 hours of half-life. Both are separately bacteriostatic, but when togetherly combined, they are having bactericidal action towards many bacteria. The dose usually given is 400 mg sulfamethoxazole combined with trimethoprim 80 mg given as BD, or 800 mg sulfamethoxazole and 160 mg trimethoprim as BD. Trimethoprim crosses the blood-brain barrier and placenta, but sulfamethoxazole is having a poor penetration. Now let's move on to fluoroquinolones. It is extensively bioavailable drug when given as orally, and it's having high volume of distribution and it is broad spectrum in nature. These drugs are mainly used in our hospital, but it is having a black box warning, that is, in case of uncomplicated cystitis, sinusitis and acute bronchitis, this is not the initial choice because fluoroquinolones can cause insomnia and tendon rupture. So this drug should be preferred only when there is no alternative options. It is contraindicated in pregnancy. When we are administering fluoroquinolone to a child, there is a chance for musculoskeletal toxicity, and it is not preferred for myasthenia gravis patient. The drugs available in fluoroquinolones are ciprofloxacin, moxifloxacin, levofloxacin, etc. The ciprofloxacin is having mainly active towards gram-negative bacilli, mainly towards Pseudomonas species, but in case of moxifloxacin and levofloxacin, it is having more coverage towards gram-positive aerobes. The dose given for ciprofloxacin is 500 mg BD, and in case of moxifloxacin, the dose is 400 mg OD, and levofloxacin it is 500 mg OD. Usually, fluoroquinolones are considered for respiratory infection which is caused by respiratory pathogens. The mechanism of action is it inhibits the DNA gyrase and it is having a bactericidal action. Now let's move on to betalactam antibiotics. It consists of penicillin, cephalosporin and carbapenem. All are having similar mechanism of action, that is, it inhibits cell wall synthesis. Let's move on to penicillins. The first discovered penicillin is penicillin G, which is also known as benzyl penicillin. It is having narrow spectrum of activity, that is mainly having coverage towards gram-positive bacteria. The dose given is 0.5 to 5 million units, which is given either as IM or IV 6 to 12 hours daily. Then came the semi-synthetic penicillin. They are divided into acid-resistant penicillin, penicillinase-resistant penicillin, extended spectrum penicillin. The acid-resistant penicillin consists of phenoxymethyl penicillin, which is also known as penicillin V. Its oral administration is better, that it is given as a dose of 250 to 500 mg 6 hourly. The spectrum is similar to that of penicillin G. Next we have penicillinase-resistant penicillin. It is having coverage towards penicillinase producing Staphylococcus species. The drugs coming under this category is methicillin and cloxacillin. Cloxacillin, when given for Staphylococcus species, should be treated for greater than 14 days. The oral dose is 250 to 500 mg every 6 hourly. Next we have the extended spectrum penicillin. It consists of aminopenicillin and uridopenicillin. Aminopenicillin consists of ampicillin or amoxicillin. Uridopenicillin consists of piperacillin. The main difference between amoxicillin and ampicillin is that amoxicillin is having slightly greater lipid solubility than ampicillin. This may lead to a slight greater action of amoxicillin comparing to ampicillin. Piperacillin tazobactam is given at a dose of 4.5 gram every 6 hourly, given over 30 minutes. Extended infusion can be given over 4 hours, given 8 hourly. The dose is 3.75 to 4.5 gram. Beta-lactam antibiotics are incomplete without beta-lactamase inhibitors. In this category, we are having clavulanic acid, sulbactam, tazobactam, vorbactam, etc. Usually, they are clubbed along with various beta-lactam antibiotics such as amoxicillin, clavulanic acid, ceftriaxone, tazobactam, meropenem, vaborbactam, cephalosporins, sulbactam, etc. They are mainly added to a beta-lactam antibiotics to overcome the resistance produced. Now let's move on to cephalosporins. We are having 5 generations of cephalosporins. At least some have found it difficult to pronounce or identify which cephalosporin come under which generation. Now let's look at each drugs coming under different generations. In case of first generation, we are having parenteral cephalosporin, which includes cefazolin, cephalothene, cefapyrin, and cephradin is also present in parenterally as well as oral cephalosporin. Apart from cephradin, oral cephalosporin consists of cephalaxin, cefadroxil. In case of second generation cephalosporin, we have cefamendol, cefonicid, cefuroxim as parenteral preparation, and in case of oral cephalosporin, second generation consists of cefaclor, cefproxil, cefuroxim, lorcerbef. Second generation also consists of cefmetazole, cefotetin, and cefoxitin. In case of third generation, we are having the following drugs: cefoperazone, cefotaxime, ceftazidime, ceftriaxone. They are panel preparations, and we are having oral preparations of third generation that are cefdinir, cefditoren, cefixime, cefpodoxime, cefibutane. In case of fourth generation, we have cefipim, cefipirom. In case of advanced generation and combination agent, we have ceftarolin, cefidrocol, ceftobiprole. And in case of when we are considering combination agents, we are having ceftriaxone, tazobactam, cefoperazone, sulbactam, ceftazidime, avibactam. Now let's discuss about first generation cephalosporin. It is having a difference between other generations. The difference is that it is active more against gram-positive cocci and limited action towards gram-negative species. The second generation consists of cefuroxime, which is available as injection and tablet, cefaclor, which is a tablet, and there are various drugs coming under second generation cephalosporins. Comparing to first generation cephalosporin, it is having less activity against Staphylococcus species but is having greater activity towards gram-negative bacilli. Now let's move on to third generation cephalosporin. It consists of ceftriaxone, cefoperazone, ceftazidime, etc. These drugs are administered parenterally. They are having less activity against gram-positive organism but greater activity towards Enterobacteriaceae. Cefotaxime and ceftriaxone is having poor activity against Pseudomonas species, but ceftazidime is highly active towards Pseudomonas, that is Pseudomonas aeruginosa species. When we administer ceftriaxone, there may be formation of ceftriaxone crystal for some patients, so this should be identified. If a patient is infected with Pseudomonas species, if you are considering third generation cephalosporin, it is better to prefer ceftazidime rather than cefotaxime or ceftriaxone. Now let's move on to the fourth generation cephalosporin. It consists of many drugs. One is cefipim. It is active as that of cefotaxime or ceftriaxone and ceftazidime. The main issue that some patient may encounter is that they may be complicated with superinfection with Enterococci or Candida species. Some may have a seizure episodes. Now let's move on to the fifth generation cephalosporin. It consists of ceftarolin. This is having an action similar to that of ceftriaxone with improved gram-positive coverage. However, when we consider altogether the cephalosporin, third generation cephalosporins are mostly preferred because of their broad spectrum coverage and lesser side effects. Ceftazidime-avibactam combination is widely used nowadays. It improves the minimum inhibitory concentration, that is, it lowers the minimum inhibitory concentration for Pseudomonas aeruginosa species. The dose given is 2.5 gram every 8 hourly, infused over 2 hours. It extends the spectrum for Enterobacteriaceae species. In a trial done for urinary tract infection, ceftazidime and avibactam combination is having similar action to that of imipenem. In case of intra-abdominal infection, ceftazidime and avibactam plus metronidazole is similar to that of meropenem. Cephadrocol is a novel cephalosporin that is having activity against multi-drug resistant gram-negative bacteria, including extended spectrum beta-lactamases or carbapenemase producing organisms and multi-drug resistant Pseudomonas aeruginosa, Stenotrophomonas maltophilia and Burkholderia cephisia. In addition to enhanced stability against beta-lactamase, it has a novel mechanism for transport across the outer membrane that can overcome the effect of membrane permeability mutations as seen in Pseudomonas aeruginosa. Cephadrocol is thought to have poor gram-positive and anaerobic activity. According to US FDA, cephadrocol has been approved for use in adults in complicated urinary tract infection and or pyelonephritis due to highly resistant gram-negative organism when there are no alternative therapy regimen. In an as yet unpublished study of approximately 120 patients with pneumonia, complicated urinary tract infection or bloodstream infection due to carbapenem resistant gram-negative organism, preliminary results suggest that larger similar clinical cure rate with cephadrocol versus best available therapy, that is colistin based regimen in two-thirds of cases. Cephadrocol also compared favorable with imipenem in another unpublished study of complicated urinary tract infection due to gram-negative organism. Now let's move on to carbapenem, which is also a beta-lactam antibiotic. It is having a greater broad-spectrum activity, having action towards gram-negative organisms, anaerobic species, and gram-positive organisms. The gram-negative organisms which it acts against are beta-lactamase producing H. influenza, N. gonorrhoeae, Enterobacteria, Pseudomonas aeruginosa. Gram-positive consist of Enterococcus, Faecalis, Listeria, etc. These class consist of imipenem, meropenem, ertapenem, etc. The imipenem should be administered along with cilastatin because unless it is not administered along with cilastatin, there is a chance for patient to have a renal impairment. Cilastatin prevents the renal necrosis due to enzyme renal dehydrogenase. So cilastatin should be administered at a dose of 500 mg IV every 6 hourly if the patient is normal renal function. The GFR less than 5 ml per minute per meter 1.73 meter square is contraindicated. The next drug is meropenem. This drug does not need a co-administration of cilastatin. The dose range of meropenem is 500 mg to 4.5 gram TID. It can be infused in 30 minutes. Ertapenem is having a narrow spectrum comparing to that of imipenem and meropenem. It is active against anaerobes and most Enterobacteriaceae and not against Pseudomonas aeruginosa, Acinetobacter and gram-positive like Enterococcus. The normal dose is 1 gram once daily. It is reserved for patients who are having resistance to other antibiotics. Another carbapenem antibiotic is doripenem. It is mainly used for urinary tract infection and intra-abdominal infection. The action is similar to that of meropenem. Now let's move on to meropenem Weber Bactrim combination. It is active against class A carbapenemases including Klebsiella pneumoniae carbapenemase. It reduces, similar to that of ceftazidime and avibactam, it reduces the minimum inhibitory concentration and produce better effect. However, it is not active against class B or D carbapenemases. In case of urinary tract infection, the dose is 4 gram every 8 hourly, I intravenously given for less than or equal to 14 days. Azithromycin, monobactam. It is having a major action towards gram-negative aerobic species. It is having no action against gram-positive species. In case of urinary tract infection, it is given as intramuscularly or intravenously. The dose is 500 to 1 gram, 500 milligram to 1 gram, 8 to 12 hourly, and the maximum dose is 8 gram per day. In case of moderate infection, 1 to 2 gram every 8 to 12 hours is given. In case of severe infection, the dose is 2 gram, 6 to 8 hourly. Usually, when we are administered with an antibiotic, the healthcare providers would give us a recommendation to take the medicine for the prescribed days without any fail. If we don't take it appropriately, there is a high chance for the resistance to occur. The antibiotic resistance happens when bacteria changes and become resistant to the antibiotics used to treat the infection they cause. They can be mainly due to overprescribing of antibiotics. The main reason behind this practice is that people are more concerned of getting the disease cured fastly. They are not concerned about the ill effect caused by the resistance pattern towards any antibiotic. We should always keep in mind that if the resistance pattern happens to all antibiotics, then there will be no cure for any bacterial infection. It would be a fatal condition and we would not like that situation to happen. The second reason for antibiotic resistance is that the patients are not willing to finish their treatment as prescribed. If the fever gets cured or the fever gets off, the patient will stop the antibiotic therapy. This is a dangerous situation, and the prescribed dose and prescribed duration should always be accomplished when a treatment is started. The next reason for antibiotic resistance is that overuse of antibiotics in livestock and fish farms. This practice is done to make the livestock or the animals who are meant to be slaughtered to be healthy, and they are not concerned or they don't care about the people who are being affected as a result of this overuse of antibiotics, and this indirectly will lead to resistance in human beings. This in turn would also affect them, which they are not knowing, as well as the society. The other reason is poor infection control in hospitals and clinics. Lack of hygiene and poor sanitation is another reason for antibiotic resistance, and there is also a lack of new antibiotics being developed. These are the reasons published by WHO, and they emphasize on using the antibiotic cautiously. On 1st October 2019, the World Health Organization has developed an AWARE classification database as a recommendation of WHO expert committee. And based on this, the antibiotics were divided into three groups. One is assess group antibiotics, second one is watch group antibiotics, and last one is reserve group antibiotics. Assess group antibiotic. These consist of antibiotics that are having activity against a wide range of commonly encountered suspected pathogens while also showing lower resistance potential than antibiotics in other groups. So these drugs should be commonly prescribed in a clinic or a hospital setting. The assess group includes 48 antibiotics, 19 of which are included individually on the WHO model list of essential medicine as first or second choice empirical therapy options for specific infectious syndromes. The antibiotics that are marked in red color are essential drugs coming under assess group antibiotics, which consists of ampicillin, amoxicillin, etc. So keep in mind that these drugs are having low resistance pattern. So try to prescribe these drugs or try to suggest these drugs for any bacterial infections unless until not required. Watch group antibiotics. This group includes antibiotics that are having high resistance potential and includes most of the highest priority agents among the critically important antimicrobials for human medicines and antibiotics that are at relatively high risk of selection of resistance pattern. Antibiotics in watch group should be prioritized as key target of stewardship program and monitoring. The watch group includes 110 antibiotics, 11 of which are included individually on the WHO model list of essential medicines as first or second choice empirical treatment options for specific infections. So these are the drugs that comes under watch group antibiotics, and those denoted in red ink are essential drugs. It consists of azithromycin, vancomycin, ceftriaxone, cefuroxime, ciprofloxacin, etc. Reserve group antibiotics. This group includes antibiotics and antibiotic classes that should be reserved for treatment of confirmed or suspected infection due to multi-drug resistant organism. The antibiotic in reserve group should be treated as last resort options, which should be accessible, but their use should be tailored to help specific patients and settings when all alternatives have failed or are not suitable. There are 22 antibiotics under reserve group class and 7 reserve group antibiotics are listed as WHO model list of essential medicines. Now look at the table. It consists of reserve antibiotics. Those marked in red ink are essential drugs. It consists of ceftazidime, avibactam, colistin, fosfomycin, linezolid, meropenem, Weber-Bactrim, etc. Now what is cross resistance? Consider a patient who is admitted to a general medicine department who is suspected to have an infection. The culture and sensitivity report was obtained and the resistance pattern was found to be surprising. He had multiple resistance patterns. But when the healthcare providers inquired on the usage of antibiotic or irrational use of antibiotic, the patient said that he had only used one antibiotic. So how this resistance pattern, wide range of resistance pattern happened? This is as a result of cross resistance. So one resistance can lead to a resistance pattern towards multiple antibiotics. This is commonly seen when a medicine is chemically or mechanically related to one another. Sulfonamide resistance would cause resistance to all sulfonamide drugs. However, resistance to aminoglycosides like gentamicin resistant strains may respond to amikacin strain. We know that amikacin, gentamicin come under same class, however the resistance pattern are different for these cases. Another aspect is that some unrelated drugs show partial cross resistance, that is, an example is tetracycline and chloramphenicol. Now, how can you reduce or prevent drug resistance? Don't inadequately prolong use of antimicrobial agents. Prefer rapid acting and narrow spectrum antimicrobial agent whenever possible. Broad spectrum should be used only when specific microorganism is not obtained. Use of combination of antimicrobial agents whenever prolonged therapy is required. In case of tuberculosis, we use multiple drugs, that is isoniazid, rifampicin, ethambutol, and pyrazinamide. So these type of combination agents should be used for prolonged administration or prolonged treatment regimen.
Thank you one and all who has attended the session and patiently listened this session. If you have any doubt, don't worry, we have a medicine assist group and send a query to +918304868938. It's a WhatsApp group and this is a WhatsApp number. You can send us WhatsApp message to this number, you will get the answer. Any medicine related questions can be asked via this number. Anyway, thanks a lot and have a nice day.